deep pain and swelling of the thigh muscles, but his symptoms kind of resolved. However, a few weeks later, the patient gradually developed recurrent pain and swelling in the same area, solitary, hard, mobile, oval mass of approximately 4 into 5 centimeters in the anterior aspect of the thigh. What do you think is happening over here?
Maybe he's a tumor because of trauma or something like that.
Myositis ossificans.
Maybe. We don't know. I mean, what do you think the answer is over here?
A.
A.
Benign metaplastic bone with surrounding fibroblastic proliferation.
Does anybody else have to pick an answer? They can go ahead, shoot in their concepts.
No, I think you're correct. It's
Yes.
A. It's yeah, it's myositis ossificans because of the muscle to bone.
Okay, so we all agree with the answer option A. Okay, let us see. Okay, why isn't it E? What do you mean by E? Where do you see E?
Ganglion? Is that ganglion cyst? Synovial cyst, gelatinous mucoid material? Should be ganglion cyst.
Yeah, very good. Okay, so we knew that we're talking about myositis ossificans. Myositis ossificans is also known as heterotopic ossification. Why? What's happened? That whenever a trauma occurs, usually they will give you a clinical vignette with saying that a horse kicked him on the thigh. They're weirdly obsessed with the horse. So whenever they're going to give you a vignette that there's some trauma injury, and then after that what happens is that bone formation starts to occur, and that's usually called as myositis ossificans. What is happening that the muscle over there, uh, it calcifies and it forms this kind of like a nodule type, that's called as myositis ossificans. And that is why if you can kind of read through the statement, you will kind of realize that they're talking about a bone ossified structure that formed because of the that kind of formed because of the trauma that occurred over here. So as I was mentioning about E, a ganglion cyst. What is the treatment of ganglion cyst? How do you treat ganglion cyst?
It can resolve on its own most times.
Yes. We don't treat it, it resolves itself with the time.
Exactly. So we don't treat ganglion cyst and it kind of self-resolves. And how do we kind of differentiate in between a ganglion cyst or a tumor? How do we do that?
Transillumination.
Yeah, it translates flash of light as you can it's radio up
Exactly. So we know
Transluminancy test will be positive in case of
exactly.
ganglion cyst because that is only the mucoid fluid.
Exactly. So we do a transillumination test. Whatever is cystic, it will kind of, like illuminate, and whatever is solid, light will not be able to pass through that. So we know how it's done. We talked about osteosarcoma. We talked about Ewing sarcoma. So, option B, they're talking about Ewing sarcoma. And then the option D, they're kind of talking about osteosarcoma. And that's very important. Liposarcoma, they won't ask you that. So if we, kind of go through it a little bit down and see what it's happening, so we know that it's triggered through trauma and it presents as a painful mass, and the histological examination will show a benign metaplastic bone. So it's kind of really an easy question that they're asking you. It's usually due to they're weirdly obsessed with horse. So whenever they give you a horse type vignette, it's always myositis ossificans. Okay. Then we go to the next question. I think we talked about this picture yesterday. What do you think? Come on, active recall. What is this?
Ewing
Ewing,
sarcoma.
Ewing,
Ewing
Ewing
sarcoma.
sarcoma.
blue cells, Ewing.
Exactly. So we talked about Ewing sarcoma yesterday. I'm not going to go through that again. Okay. Question number 3. What's happening? What's this?
Ascending lymphangitis, ascending. So from the hand, moving proximal
It's
to
just
the
Okay.
arm.
skin
Okay.
reaction.
So we see that there are some bumpy lesions, and they're kind of he's having a skin reaction on like the this part of the wrist. We can see that. So now we can see the vignette, what's happening. 46-year-old man comes to the office due to skin lesions. He first noticed a small papule on his left hand that increased in size. All right. The lesions are not painful. That's very important for you to, kind of divide. The patient has never had any similar symptoms. He does not have any fever, no medical history, no allergies. Fluid aspirated from a lesion is examined microscopically. Several elongated yeast cells with narrow buds are visualized. Which of the following risk factors is the most likely accompanying the patient's history?
B. Contact with the soil and plant materials.
Yeah. So what is this? What is this condition called?
It's a sporothorax.
Exactly. And how do we treat
Protrax
it?
Shanky.
Because of plant, because of thorn, if he's planting or something.
Exactly. And how do we treat it? What's the treatment?
Uh, uh,
Itraconazole.
yeah,
So it's
itraconazole.
itraconazole. All right. So we know that it's sporothrix. So we're gonna do that. And yeah, so it's a sporotrichosis. It's because of the sporothrix. It's a fungi. It's usually present in farmers. So you will see kind of like an ascending sort of pattern of the bumps that you will see. And it's also known as ascending lymphangitis because it kind of inflames the lymph nodes as you're going up. What I want you to remember is this thing, that cigar-shaped yeast with narrow base budding. That's very high yield for you to remember because they give these lines in the pathology of the stem and they ask you what's happening. So that's very important. The treatment is really important. It's itraconazole. So yeah, okay. What about where do you see bad guano environmental exposure? What disease is that?
The histoplasmosis
Histoplasmosis.
due
Very
to
good.
exposure to case or exploring case.
That's yes.
Where do you see prolonged antibiotic use? What's this?
Membranous colitis.
Okay. Where do you see exposure?
CD. Mm-hmm.
Yeah. So usually with prolonged antibiotic usage or in patients who are immunocompromised, we see that they are prone to Candida infections. We're talking about fungal infections over here. So we see that they have Candida infections. Usually it occurs in patients who are immunocompromised for a very long time, such as if they have HIV, if they have diabetes mellitus. So it's kind of in immunocompromised patients. And even if you use a lot long-term antibiotics, it can kind of decrease your immune system's tendency to fight off infections, and that is why you get prone to Candida. So that's important. Flea bite, for that's very important, that flea bite can transmit through Bartonella henselae. That's usually a cat scratch disease. This we will teach you in the microbiology high yield topics. But yeah, for you over here right now, it's really important for you to know that what this is. This picture is very high yield for you to remember the treatment and how it kind of looks like. All right. Okay, next question. All right, so we have a patient who comes with the muscle weakness, began 6 weeks ago, worst in the hips and shoulders. All right, weakness has had a progressive course. He has difficulty rising from chair, combing hair. Okay, nothing significant, no history of spinal injury, no neck pain. PMH is insignificant. Patient takes no medication. Okay, so they gave you the answer in this. What's this? Muscle biopsy reveals major histocompatibility complex molecule expression in the sarcolemma with CD8. What do you think this is? It's a very, very easy thing they gave us. What's the answer?
Polymyositis.
Polymyositis.
Polymyositis. What if it would have been a CD4 lymphocyte infiltration? Then what?
CD4 with the dermatomyositis.
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 Very good. So we know that they gave it in the wing that they're talking about polymyositis. Okay. So this is polymyositis. We know that it's a symmetrical proximal muscle weakness. They will have elevated enzymes such as CK, aldolase. Biopsy findings are usually very high yield for you to remember because they're going to give you again and again in the question stems. Okay, this is the biopsy. This is the pathology. What is the disease? All right. So it's very important that you kind of make yourself familiar with how it is presenting. Associated complications are sometimes really important, but in this case, it's not high yield. What is dermatomyositis? Can anybody tell me what's dermatomyositis?
I know it manifests as a skin lesion, and the what is that? It has is it heterotrophs rash on the face?
Yes,
And the CD4, yeah.
so dermatomyositis is exactly like polymyositis plus skin manifestations. So whenever you have muscle problems that are sounding exactly like polymyositis, but then they go like, oh, they have skin manifestations as well, then that becomes dermatomyositis. All right. But dermatomyositis, what I want you to kind of remember with that as well, it's kind of associated with ovarian adenocarcinomas as well. And the other thing that I would want you to remember that I will tell you in the future modules. It's kind of related to skin pathology as well, but dermatomyositis has growth-in papules. They will talk about that. How do you treat dermatomyositis and polymyositis? How do you treat that?
Steroids.
Yeah. So whatever autoimmune condition, usually steroids. Yeah. So they have. So what is this?
Rotten
This is
papules.
heterotrophs rash.
Anybody else?
It's a heliotrope rash.
Heliotrope rash.
Yeah. So it's a heliotrope rash. Gluten papules are usually present on the hands, knees. They're present over there. This is a heliotrope rash. Kind of very, very, very high yield for dermatomyositis. You also see CD4 lymphocytes over there. That's very important for you to remember. And yeah, that's it. If you kind of go through this, they're talking about CD8, how it's that. I think we have discussed polymyalgia rheumatica, polyarthritis nodosa, myasthenia, Lambert-Eaton, diffuse systemic sclerosis. Okay, what is systemic sclerosis? What do you mean by that? Systemic sclerosis, guys, what do you mean by that?
Tightening of the skin, fibrosis, sclerosis, hardening of the skin, fibrosis.
Mm-hmm. What type of autoantibodies do you see in them?
Is it SCL17?
SSCL.
Anybody else?
Yeah, SSCL. SSCL17 antibodies.
Yeah. Also, how many types are there?
Fused and localized.
What do you mean by diffuse?
I think in the diffuse there is the systemic sclerosis, the involvement of all the viscera, the crest syndrome was also there.
Yeah, so in limited, so this is systemic sclerosis that we were talking about. In limited, we have CREST syndrome, calcinoid phenomena, Raynaud, esophageal dysmotility, and then you have sclerodactyly and telangiectasis. That's limited. Anticentromere is the antibody that's found in limited, and in the diffuse form, what do you see?
Yes, there is widespread skin involvement in the diffuse form.
What do you mean by scleroderma? What do you mean by that?
Derma means skin and sclero mean fibrosis.
So are systemic sclerosis and scleroderma same or are they different?
Yes, that is same.
Exactly. So, yeah, that's what I wanted you to know. I'll go on to the next question. All right. So, they're talking about a 27-year-old man who's coming to the ED due to several hours of right foot pain and swelling. The patient says he was working in his barn last night and he stepped on the old nail. Okay. So now he has pain on that old nail. He has progressive swelling as well. He has fever. His blood pressure is a little high, right foot is swollen, and there is just some erythema along the injury site. Oh, what are they talking about? What has happened? There's gas.
Gas
Gas
gangrene.
gangrene.
Gas gangrene.
What's the disease called?
Preferences, Clostridium preferences. Or the
All right.
disease or the bacteria.
Okay. So we know that there is some gangrene, or there's this usually the gas they're talking about is carbon dioxide, and because of that, the tissue has become necrotic. Which of the following best describes the mechanism of the action of the toxin? So what do you think the answer is?
D. Phospholipids splitting, I think.
Okay, so why isn't it presynaptic acetylcholine release? What's this?
Clostridium botulinum.
Lambert Eaton. That is the Lambert Eaton.
Exactly. What do you mean
Uh,
by,
so
where do you see elongation factor ribosylation? Where do you see that?
Diphtheria.
Diphtheria and Pseudomonas aeruginosa.
Very good. Where do you see plasminogen activation? It's not linked to that, so we will eliminate that. T cell
Group A
It's
Group A
streptococcus.
Streptococcus.
Mm-hmm.
Where do you see T cell hyperstimulation?
Staph
Staph aureus.
aureus.
Yes,
Very
yes.
good.
mhm.
So where do you see
Excuse me.
carbohydrate?
Sorry, Dr. Maheen, the presynaptic acetylcholine release inhibition is with the botulinum.
Yeah, botulinum.
Am I
Yes.
right? Yeah. Uh,
This occurs with the botulinum. Presynaptic calcium channel release occurs with the,
inhibition is with botulinum. Am
yeah,
I right? Yeah.
Yes.
Oh.
yes.
Mhm.
Okay. So where do we see carbohydrate degradation?
Also in CD, sorry,
Phospholipids.
in preferences, but it's for gas production. It's also in preferences.
Okay, so we agree with the phospholipid splitting. This is the this is what the chart. Diphtheria toxin, elongation factor, ribosylation. That's what we talked about. Pseudomonas aeruginosa, again, it has exotoxin A, and it does the same mechanism of diphtheria. S. aureus has usually two toxins, enterotoxin and TSS toxin. TSS toxin is usually associated with what?
Toxic
With,
shock syndrome, staph aureus.
it's usually
Tampon or
associated
packing.
exactly in
Tampons and packing.
nasal packing, or with tampon usage. If a woman comes and she has gone into sepsis after using a tampon, that means it's TSS toxin, widespread cytokine release. C. difficile is usually found in pseudomembranous colitis due to prolonged antibiotic usage. Botulinum, it blocks the presynaptic release of acetylcholine, that what we discussed. It's flaccid paralysis. Pertussis, we know what it does. It increases the CAM. Then we have chlorellotoxin. Again, it increases the CAM. C. perfringens, that's alpha toxin. So all of them are very high yield for you to remember. These bugs are really important in how they kind of work through. What are they blocking? What are the clinical features of that? And how do you control them? So that's very important for you to remember over here. And yeah, I think so. We talked about nothing to kind of built on the concept. It's just root memorization. You just have to memorize how they're functioning. Okay, so we know lecithinase was an alpha toxin and it's produced by C. perfringens. It degrades lecithin, and we know that it causes necrosis, it causes membrane destruction, cell death, and hemolysis. All right. So we talked one more thing also causes gangrene. What's the other thing that causes gangrene?
Diabetes.
Yes. Anybody else?
Mucor, mucor fungal,
What
mucormycosis.
mucor and rhizopas, they
Yeah.
cause they're the funguses that cause gangrene sort
Mhm.
of things, picture in diabetes mellitus patients or
Mhm.
even in immunocompromised patients. All right, so we come to the question number 6. All right, so we have a 34-year-old man comes to the physician reporting 1 week to inability to extend his right wrist and several of his fingers on the same hand. Okay, so he had difficulty while trying to type his thesis for graduate school on his computer. He is right-handed and does not recall any trauma. He has a history of asthma that was diagnosed while he was in college. Physical examination demonstrates impaired dorsiflexion of the right wrist. All right. So the picture, what is wrong with the picture?
Eosinophilia.
Okay. And neutrophil myeloperoxidase are positive. What do you think the answer is?
Eosinophilic granulomatosis with polyangiitis.
Jock Strauss, yes.
All right. Why do you think why do you think it's this? Why isn't it ABPA?
It's neutrophilic myeloperoxidase positive, that's Pianka positive, and there's history of asthma, there's eosinophilia. So that just tells you Jock Strauss.
Very good. If it would have been allergic bronchopulmonary aspergillosis, they would have probably mentioned it, and then this wouldn't have been positive. So it's very important that you kind of go through it. It's a vasculitis question. We know that Turk Strauss is, it's a triad of asthma, rhinosinusitis, and eosinophilia. It's a vasculitis component. You usually see two main things for you to remember: eosinophilia, very high, and then you also have the positive for neutrophil myeloperoxidase. One more thing, where do you see eosinophilia more? In what conditions?
Hypersensitivity,
Parasitic infection.
allergies,
Allergic and
allergic
parasitic.
reactions.
Parasitic
Parasitic
infections.
infections.
All
PMS.
Parasitic
parasitic,
infections.
yeah, helmet, yeah.
Parasitic
Yeah,
infections.
good. So you see eosinophilia in helminth infections and sometimes in fungal infections as well, in ABPA. You also see eosinophilia in one more kidney disease. If I'm forgetting it, what that kidney disease is, but you see eosinophilia.
Acute interstitial nephritis.
Interstitial.
No. Yes, interstitial. And what else? I'm forgetting it. So I'll get back to you with this. I'm forgetting it. There's one more thing that you get eosinophilia in where the kidneys get hijacked. I think what disease is that of the kidney in which all of the three hormones do not, they stop getting produced? Adrenal insufficiency. Yeah, I forgot. So in adrenal insufficiency, you also see eosinophilia. All right. So in adrenal insufficiency, you will see that in interstitial nephritis, you're going to see that you're going to see that in helminth infections, in allergies, hypersensitivity. All right. So eosinophils are really important for you to remember in that context. Okay. So we know that, but it's right. All right. Okay. Other thing that I want you to remember, what is anti-glomerular basement membrane antibody disease? What's this?
Good posture.
Good postures, yeah, good posture.
What do you see? What's the vignette of? What do you see with the kidney?
It's oh,
Antibodies develop against the basement membrane.
Exactly. So what you see nephritis, and you see rapidly progressive glomerulonephritis along with hemoptysis. All right,
Mhm.
that's good, Pastor. All right, systemic sclerosis. We already talked about that. I think. Okay, we'll move on to the next question. All right, so temperature is really, it's okay, it's high, blood pressure is okay, pulse is okay. Left knee is swollen, erythematous, warm and tender with restricted active and passive range of motion. Which of the following is the best next step in, oh, I think I told you this. I told you this. Which of the following is the next best step?
Synovial fluid analysis.
Very good. Somebody's been paying attention. Very good. So whenever a patient with arthritis is coming to you, what is the first thing you do? Get arthrocentesis and then, kind of go through the disease. So yeah, and remember, every joint pathology can cause septic arthritis. So it's not necessary that it's either gonococcal or non-gonococcal. It can be any joint pathology. It can be rheumatoid, gout, osteoarthritis, whatever, psoriatic arthritis, whatever joint pathology is there, it can trigger septic arthritis. All right. So that's why you need to figure out what the cause is by doing arthrocentesis. And based on the arthrocentesis results, you kind of provide the treatment for the patient. All right. No matter if he's dying, no matter if he has a fever, they don't care. All right. So we first do the synovial fluid analysis. All right. 8th question. Okay. So her blood pressure is 130/70, a little bit high, but okay. Neurological examination, including cranial nerves and motor and sensory functions, are unremarkable. Visual acuity, visual fields, and appearance of the ocular fundi are normal. Which of the following is the initial best test? So there's a 68-year-old patient, vision disturbances, episode of dimming of vision in the left eye that occurred abruptly and resolved spontaneously in 20 minutes. What do you think is happening? What's this called?
Giant cell.
Cancel
Am-
arthritis.
Amaurosis?
Yeah, so this
Amaurosis figure.
Arthritis. Cancel arthritis.
exactly. So this condition is called as amaurosis fugax. That is known as a transient blindness. And why? Why is it transient blindness occurring? Why is it, she's losing her vision and then she's getting it back?
Arterial occlusion.
Because of sudden occlusion of ophthalmic artery.
Okay, because of what?
Because of arthritis, giant cell arthritis, it can involve it leads to ischemia of the ophthalmic artery.
Okay. Also, amaurosis fugax can also occur in carotid artery diseases. For example, if you have an atheroembolism that gets dislodged from a carotid artery, and then it can also cause like temporary blockage of the ophthalmologic arteries, all right? Because carotid arteries, they go and they bifurcate into the eye arteries as well, all right? So amaurosis fugax can also occur with patients who have carotid artery diseases as well. Oh, I gave you the answer. Damn. Okay, what do you think is now the initial step? I gave you the answer.
ESR.
Yes, sir.
ESR? No, I just said carotid artery, carotid artery. How do you monitor?
Sorry.
Oh,
Angiography.
Angiography.
Here we go.
Yeah,
Angiography.
angio.
Angiography.
Or maybe I'm distracting you. Maybe it is ESR. Then what? You guys need to
But-
figure it out for your own
No, I'm
sake.
sure it is ESR. If it is giant cell arthritis.
Best initial test for the patient shouldn't it be ESR?
Yeah, very good. So whenever I confuse, it's a confusion strategy. You need to stick with your initial answers because that is what USMLE does. It confuses you a lot. All right. So which initial test, we will always go with the metabolic markers. All right. With the metabolic profile, with the hormonal profiles, or even, the serum markers. Initial tests are always laboratory blood tests. All right. We don't go and admit a patient for angiography when we haven't had the profile. So that is why it's important that you kind of know what that is. So it was giant cell arteritis. All right. We know that ESR is very important in that. And I think I mentioned that in polymyalgia rheumatica, you'll see ESR, and that's kind of the differentiation between fibromyalgia and polymyalgia rheumatica. And then you do temporal artery biopsy. Amaurosis fugax occurs in a lot of conditions. Giant cell arteritis is one of them. The reason that angiography was over there was because in a lot of patients who had myocardial infarction in MI or even heart-related issues, they also suffer with amaurosis fugax. For example, when you have carotid artery stenosis, all right? So whenever you have carotid artery stenosis and you are having a transient blindness, transient vision blindness, that's also called as amaurosis fugax. So you kind of do the angiography of, there's this thing called, that's a carotid angiography, CRA, and you do that of the neck, or sometimes there's in advanced USMLEs they ask about MRA, that's MR angiography. You do that and you see that if there's any blockage of that artery that's causing amaurosis fugax. Okay, so it's not a heart-related pathology. It's a pathology of arteritis. So that is why we put ESR. And the other thing would be probably biopsy. All right. Yeah. So we talked about that. Nothing. What you do is you give steroids. Steroids are very important. Otherwise, ischemic optic neuropathy occurs. Very high yield for you to remember it. Okay. Yeah. I think I saw a CDA over here. Where is it? I think I saw it over here. Okay, no, I didn't. All right. So that is why you do it and you kind of help with that. All right. Next question. Does anybody have any question up till now? They can ask me, they can unmute, they can ask me, and then they can clear their concepts. No? Okay. 24-year-old woman, persistent facial rash, develops sunburns, and her tip fingers turn blue. What is this phenomenon called? What's this?
Raynaud's phenomenon.
Raynaud's phenomenon.
Very good. How do you treat Raynaud phenomenon?
That I don't remember. Sorry, doctor.
What do you give? What is the treatment for Raynaud? CCB. So you give calcium channel blockers for CCBs, for Raynaud. And so the patient is having facial rash, sunburns. She also has a facial, it's a very, very segue butterfly rash. And yeah, so targets protein. All right, so we know that they're talking about SLE. So what do you think the answer is over here?
Removal of introns from RNA.
It's an anti-Smith, yeah, and it attacks the E.
So we all agree with her answer choice E. We all agree with that. All right.
Yes.
Okay. So we know that the patient has SLE. What is happening in SLE? In SLE, you see malar rash or the butterfly rash. You see photosensitivity, Raynaud phenomena. What else do you see in SLE?
Lupus nephritis. It's complication.
Hypercoagulability, thrombosis.
Yeah.
You also see pancytopenias. What else do you see? Joint problems. What else do you see? Kidney problems. What else do you see?
It's systemic.
Many problems.
There are a lot. It's systemic. It's a lot.
Yeah. What else?
Problem.
What else do you see? What else is happening in SLE? How do people die from SLE? How?
Nephritis. Glomerulonephritis.
Kidney failure.
Lupus nephritis. Yeah.
Most common cause
Kidney
of death
failure.
is kidney failure.
Yeah. So I think now that cause has changed. Previously it was kidney disease, but now because the modern treatment has come, so now people don't die as much of kidney failure in SLE. I think now the cause is different, but I may be wrong as well. Search it on the internet and see what the answer is. But yeah, so we know that what's happening in SLE. What type of antibodies do you see in SLE? What type of?
Anti-Smith, anti-GS, DNA.
Exactly.
There was DNA and one more. I forgot. I'm sorry.
And ANA is sensitive, but it's not specific.
Exactly. So you see ANA, anti-Smith, anti-double-stranded DNA. There is also this thing called drug-induced lupus. What drugs cause drug-induced?
Isoniazid,
hydralazine, and the proconamide or something.
Yes,
Very
proconamide.
Hydralazine, isoniazid, proconamide.
Very good. Yes. So
and we're gonna see antihistone antibodies, yeah?
Very good. You see antihistone, yes. So yeah, so it was again a memorization based answer. You know what it does. We know that the siRNA is synthesized by the RNA polymerase II in the nucleus and complexes with the specific proteins to form smaller nuclear ribonucleoproteins. SNRMPs are very central, crucial for spliceosomes, which remove introns from pre-mRNA to form mature mRNA. Patients with SLE can have autoantibodies directed against SNRNPs, and that SNRNPs is known as anti-Smith antibody. All right. Okay. We can go to the next question. All right. 34-year-old woman comes to the office with several months of vision problems, difficulty chewing, and trouble speaking. All right. The symptoms are fluctuating. She works as a telemarketer and has been putting on increasingly long hours to meet her quotas. Regarding her symptoms, she says it's probably just exhaustion. An ice pack helps my face. During physical examination, patient is asked to keep her. Okay, they gave you an answer. She has diplopia, chewing, trouble speaking. What do you think the answer is?
Myasthenia gravis.
The pathogenesis of the patient's disease is most likely similar to which of the following conditions?
Is type 2 hypersensitivity, autoimmune, good posture.
Good
Yeah.
postures.
What is happening to the patient?
Myasthenia
Myasthenia gravis.
gravis.
Exactly. And what happens in myasthenia gravis?
Antibodies against the postsynaptic acetylcholine receptors.
Exactly. So we know that it was myasthenia gravis. Where else do we see diplopia in?
Botulinum, botulism.
Also Lambert-Eaton syndrome. You may see diplopia and Lambert-Eaton syndrome, but the main segue is that proximal muscle weakness occurs first in Lambert-Eaton. You have absent DTRs. Along with that, you also have diplopia. In myasthenia gravis, you do also have muscle weakness, but it's the it's the pattern that's happening first. So they told us about it. The vision problems is happening first. I told you that you have difficulty chewing and difficulty speaking as well. You have dysphagia, you have dysarthria as well, and they are the main problem in myasthenia gravis. In Lambert-Eaton, the main problem is the muscle weakness. All right, that kind of helps you distinguish both from one another. And yeah, so what treatment do we give in myasthenia is pyridostigmine. We give the patient that along with steroids. Also, there are many types of myasthenia gravis: relapsing, remitting, continuous, many types of myasthenia gravis. You don't need to go and learn the details of it. Good pasture is kind of like myasthenia gravis. Why? Because we have the production of autoantibodies against type 4 collagen. That's very important. It is kind of like hypersensitivity type 2. All right. It is against the alpha 1 type 4 collagen. So how I remember it is 214, which means type 2 hypersensitivity, alpha 1 of the 4th collagen. So that's how I remember 214, if you want to remember it. And these antibodies cause inflammatory destruction of the lung alveoli and the renal glomeruli. That is why we're having rapidly progressive glomerulonephritis, where we see the crescent shape, and we have hemoptysis that's occurring. All right. Okay, so we talked about that, and let's come to the last question. All right, so last question for today. 65-year-old man comes to the ED due to a 3-day history of headaches in the temporal region. Okay, intermittent blurring of vision in both eyes, felt fatigue, stiffness in the shoulder and hips. On examination, okay, there's tenderness of palpation to the right temporal region with enlargement of the underlying artery as shown. Let's see what the picture is about. All right, so you see that there is something going on over here. We don't know yet, so let's read the question. Edematous optic disc in both eyes. The patient has limited active abduction of shoulder joints bilaterally. ESR is elevated. What is happening?
Giant cell arthritis.
All right. And what is the muscle weakness that's associated with them? What's that?
Polymyalgia rheumatica. Muscle stiffness. Polymyalgia rheumatica.
All right. What do you think the answer is?
Interleukin 6.
Interleukin 6.
All right. Where do you
Because
see Okay.
Because it is the inflammatory process and ESR is much high. Inflammatory process, cytokine mediated is the interleukin 6.
Okay. Where do you see antibodies to proteinase 3?
That is C anchor positive, so that is for Wegener's.
Okay.
It's C anchor for Wegener's.
Okay.
It's Wegener proteinase 3.
And myeloperoxidase?
That's P anchor. That's for Chuck Strauss.
Okay.
Neutrophil myeloperoxidase, yeah.
So we know it's interleukin 6. We talked about that. The production of cytokines, particularly interleukin 6, it appears to closely correlate with the severity of the disease. They are saying that there's this new monoclonal antibody that they want you to remember for step 1, tocilizumab. That's relatively new in the USMLE step 1. Steroids, but now they also give, along with steroids, they give tocilizumab. So this, if you kind of want to remember it. I was talking. Can you mute yourself?
I
All
think
right.
Dr. Victor.
All right, so I think tocilizumab, kind of important for you to remember, along with steroids, you get that in giant cell temporal arthritis. We know that interleukin 10, it's an anti-inflammatory and it helps in the immunomodulation. If you have defective IL-10 signaling, then it is associated with IBD. That's important for you to remember. So 6, 10, that's very important for you to remember. We know that myeloperoxidase and proteinase 3, where they're found. Proteinase 3, it's found in GBA and granulomatosis with polyangiitis. And we know that anti-neutrophil cytoplasmic antibody, they're associated with microscopic polyangiitis. So yeah, I think we're done for the day. If you have any questions, and you can ask me, then I think Dr. Ahmed will be joining you. All right. Any? Okay, yeah, Judith, I see your hand raised.
Yeah, please, I don't understand the 214 mnemonic that you give us. Is it for a type of hypersensitivity reaction? I did not get it. Sorry.
Okay, I'm typing it in the group chat. You can see that. All right.
Okay, thank you. Okay, thank you.
Anybody else? Yes, Christine. Do you have something to say? All right. Does anybody else have anything to say? No? Yes, Dr.
Thank you, Doctor.
Hi, hello.
Yeah.
Thank you,
To
Doctor.
ask concept about that SLE was related to that mRNA, those stuff like DNA part. I couldn't, I don't know that concept. Can you please explain how SLE connects with that answer?
With DNA?
That Reynolds phenomenon, one question, maybe 8th or 9th question.
Yeah, so how SLE is connected with Raynaud's? Is that what you're asking?
No, not Reynolds. I know about Reynolds phenomenon, but like the answer, like the DNA genetics part.
Oh, no.
The
The genetics,
introns.
anti-double-stranded DNA antibodies are found within the SLE.
Okay, it's a characteristic.
Yeah.
Okay,
Very
okay.
specific. All right.
Okay. Thank you so much, Dr. Maheen. It was wonderful session.
Thank you. Is there anybody else? I see one more hand. Yes, Muskan.
No, I just wanted to ask you now, are you satisfied with our response?
Yeah, I'm very satisfied. You guys are doing very great.
Thank you so much. That's good. We just don't want to make you upset.
Sometimes more knowledgeable than me as well. Even then, I have to see that, oh, okay, I'm wrong. Let me just go. Yeah, really. Good job, guys. Good job.
Thank
All
you,
right.
Doctor.
Yes, Christine. Do you have anything else to say? Yes, Kems?
Uh, yeah, good morning. This is my first day with you guys. I just want to know, eh, is there any another platform to do your work question? Because I don't know. Yesterday, doctor, um, I received the task, but I don't know how to do it because I don't know if you guys have another platform to do your work question.
Yeah, so we are a platform. We share tasks daily, and our students do the tasks. Usually, if you have any sort of management type of questions, then you can ask Dr. Laiba and Dr. Hamza, and they will get back to you. All
Dr.
right.
Hansa. All right, thank you.
Okay. Okay. If anybody else does not have any question, then I will log out of the session. You guys can log out as well. I think the next link will be shared in the group if Dr. Ahmed is having a session or not. I don't know about that. You guys will be updated on the group. So I'll see you guys tomorrow. And yeah, who else is joining the research webinar that we're having tomorrow? Who is joining the research webinar that we're having tomorrow?
I will
Yes.
be
We
joining
all.
it
I'll be
tomorrow.
joining
Yeah.
it.
Oh, John.
Yeah.
Dr.
Mhm.
Maheen, I have a question. I'm so sorry.
Yeah, sure. Go ahead, Victor.
I had couple, publications, articles, so all the,
Mhm.
like it's been submitted, and like the last one was last year. Is it gonna work, or I have just to have
No,
the?
no, it's gonna work. It's gonna work. Any publications you've had throughout your lifetime, they are valid and they will work. So the reason that we're having a research webinar tomorrow is a lot of students came up and they asked us if they don't know how to do research, especially if they're older graduates. They have graduated medical school since a very long time and they're looking to start their publications journey. We recognize that every residency program in the United States is looking for people who are having publications. So they won't consider your application if you don't have even a single publication on your profile, not only in terms of United States, even in your home country. If you want to do your own home country residency, then also they want publications on your CV. So we're having a research webinar tomorrow. I will be hosting it. We will be having two wonderful amazing guest speakers. One is Dr. Abdullah, the other is Dr. Manahil. Dr. Abdullah is working at as a research intern at Mayo Clinic. He has had vast research experience and he was priorly placed in Kansas State University as well. Dr. Manahil, again, an experienced research mentor. They both will be there as guest speakers tomorrow, and they will talk about a little bit of their journey, how it's important, and how meta-analysis is important. So tomorrow we will be having a research webinar. I will be telling you the pros and cons of research. There are no cons, but just for the sake of it. And yeah, see you guys tomorrow in that webinar. And if you guys want to bring in your friends, your colleagues, you're more than welcome to do so. And I will see you guys tomorrow. Okay.
Doctor, timing will be the same around this
Yeah.
time?
Yeah, it's going to be 10 a.m. EST. I think we shared the posters on the group. I haven't seen it as of yet, but I think it's 10 a.m. EST. So I think the times will be the same. Yeah.
Thank you so much. Thank you.
All right.
Is this research or I have a question. Is this research webinar for like to encouraging us to do the research, like, or are you going to manage some research work for us?
No, we are going to. So after the webinar, we'll be having an open registration. Where we will only entertain people who are actually willing to put in the efforts for research. We recognize that you guys are in different stages of preparation for step one. So those of you who have an exam, probably in the next month or so, then it's really hard for you to put in the same amount of effort in research. So we recognize that. So it will be only for those people who will, who are very willing to be participating in the research, because we will teach you how to do research from scratch in that group after that webinar. And we want everybody's input in that. Dr. Hamza, Dr. Laiba, Dr. Ahmad will share the details of that research workshops that we will be conducting after the webinar. So the webinar is basically an introductory session of what we plan to do and how we plan to do it, and who are the research mentors who will be there for you guys. So you don't need to worry about that. We will be walking with every step of the journey.
Okay, thank you.
All right, Dr. Huda, yes?
Thank you so much, Dr. Maheen. My question is that after the webinar, would it be the workshops to learn how to do research, or would we be actually doing a meta-analysis?
You will be actually doing a meta-analysis, but for that we cannot have 200 students in a group, right? So we will break them down onto 8 to 10 students, which we feel that they're committed, and we will be having a lot of groups. In every group you will have a research mentor assigned. You will have a research who's leading the team, a research lead assigned, and we will also be a part of the group, and they will tell you how to do it. They will teach you how to do it. Again, further details will be shared by Dr. Hamza and Dr. Laiba. I'm hoping by tomorrow they will share all the details. But as of now, we're having a webinar, and then further details will be shared on the groups. All right.
Thank you so much. Highly appreciate it.
Okay, guys, I'll see you guys tomorrow. And yeah, all right.
What time is the research webinar, Dr. Maheen? I forgot actually.
The poster is already shared in the group.
Tomorrow, 10 a.m.
Oh, okay, thank you.
All right. Okay. So I'll see you guys tomorrow, and yeah, good luck with your prep. It's going to be 10